in broader terms. All right? So let me illustrate this a little bit more. Now, let me tell you a study I am currently doing. I want to investigate how gender and sexual orientation affect the perception of depression symptoms. I hypothesize that men and women with the same depressive symptoms would be evaluated differently. Wow. The traditional mental health approach says that depression, and you know this, it's in the WHO thing every year, right? Mental health research, that depression is predominantly a female experience in risk, prevalence, and incidence. Females are almost twice as likely compared to males to experience depression. Females also have a notably increased chance to receive a diagnosis of anxiety or somatic concerns compared to males. We know that currently depression is the leading cause of global burden among women. The lifetime prevalence of depression among women is 10 to 25% compared to males, which is only 5 to 12%. Now, the thing is, this female preponderance may in part be attributed to artifactual determinants. Females appear to be more depressed compared to males because of methodological problems or artifacts in investigating or evaluating depressive symptoms and clinical depression. In other words, the traditional research approach makes it appear that females are more depressed than males, even if there might not be any fundamental difference in risks, prevalence, and incidence between the sexes. Okay, now, and we see this in other research. One key source of artifactual determinants is clinician bias. In a sample of, this is in one study, in a sample of 19,000 adults, one study found that primary care physicians were more likely to ascribe a set of symptoms as depression when the patient was female. I don't know about you, but that's shocking. Other researchers have found that physicians were more likely to prescribe antidepressants and anti-anxiety medication to women than to men, though both had similar diagnoses. This bias extends beyond mental health. For example, women are less likely to receive a diagnosis of heart disease compared to men, even when presenting with similar symptoms. In an experimental study, when physicians were asked how confident they were in their diagnosis of a male or female patient presenting with similar cardiac-related problem, they reported more confidence in assessing the male patient, because we expect men to have cardiac problems. I want you to think about that, and the implications of psychological and behavioral dynamics we do not do in our research. I love being a psychologist in public health, because I'm doing what you're not doing, and you should be doing it. All right? So, now, but for me, these artifacts offer us opportunities for extending our research and innovation capabilities. If a physician is more likely to diagnose a female patient with depression than to diagnose a male patient with cardiac problems, imagine the policy and programming implications. If women have been socialized to express their emotions more than men, and if men have been socialized to feel threatened in their masculinity when told about a chronic illness, imagine the implications for policies and programming. Say for the ways we do hypertension efforts, for instance. Now, one more, if I may. I'm doing another study on preferential biases. And what I'm encouraging you, right, mental health research, if you're expecting mental health research data on how many Filipinos are depressed or anxious or whatever, you're going to be sorely disappointed. That's not the kind of research I do. Mental health stuff like that is a minuscule of what actual mental health is. And this is an example of that. This is preferential bias. I'm doing a small study right now, and a preferential bias is a tendency to favor someone because of some belief or perceived trait about that person. Now, and what I did was a very simple randomized controlled experiment. I wondered, is there preferential treatment or bias towards other Filipinos of lighter skin color and Chinese-sounding names? You're laughing because you know what I found. This is relevant for us because if we look to Philippine social science and to Filipino literature, in the Philippines, historical social-cultural structures suggest implicit preference for lighter skin color and perceived prestige or advantage for Filipinos of Chinese descent. Although skin color and ancestry has absolutely no bearing on your abilities or your traits, contemporary Filipino culture might contain ancestral representations of historical biases. Okay? And we know this happens every day. All you gotta do is this. The next time you see an interracial couple, right? The interracial couple, here in the Philippines, this is a stereotype and it's a terrible one, unfortunately. The male is usually older and white. The female partner is Filipina and younger. Okay, that's not interesting to me as a psychologist. To me, that's whatever. The next time you see that couple, don't look at them. Look at the people looking at them. And this is what you see. That says something about the psychological and behavioral dynamics we have of people of interracial marriages or couples. It does. It says something about us. And I gotta tell you, it's not good. This is relevant for us because, it's pretty easy, right? It's a randomized controlled experiment. I asked students at UP Manila to read vignettes. It's very easy. All they gotta do is read a story. And in the skin color scenario, one condition included a picture of a subject in lighter skin tone, and then the other condition showed the exact same picture, but with darker skin tone. Okay? That is one side of the experiment. On the other side of the experiment, the subject had a Chinese-sounding name, right, with Tan and Lin. And in the other condition, the subject had the last name of Reyes or Santos. Remember, these are vignettes, these are just stories. All the stories were the same. The only thing difference was the last name on the right and the skin tone on the left. You know where I'm going with this. I asked students to evaluate the subjects of the vignettes. They were more likely to view in positive terms the subject who had lighter skin color and had Chinese-sounding names. The implications for policies in programming, to me, are numerous. This is the stuff you're doing that you don't think you're doing, but I know you're doing. What does this suggest about hiring practices of organizations, especially public institutions? What does this suggest about who gets promoted in your workplace? What does this suggest about interpersonal dynamics and even something so benign as a department meeting? Never mind the implications for field work when we go to Mindanao or to the mountains of northern Luzon. Never mind the implications for our working relationships with foreigners for multilateral organizations. Finally, the time is also right to scale up Psikologiyang Filipino. Sorry. Thank you. You know, as a profession and academic discipline here in the Philippines, mental health in general and psychology in particular are seen as extensions of the West. There is now a very real opportunity here, and I invite you to think about this when you leave, to question unchallenged assumptions and to prioritize indigenous Philippine psychology. And there is such a thing. There is. It's good stuff. It's good stuff. You gotta read early indigenous psychology from the 1960s and 1970s. It's so good. It's so good, and I encourage you to read it. Feelings, thoughts, and behaviors are inevitably culture-bound. They are. I know this. I know. You know. I was born in Iloilo, but I grew up in California. I grew up in the States. And as much as I take pride in being a Filipino, I know I'm American. I mean, I grew up there for 24 years, so I know I'm Filipino. There's some things here I cannot get used to. I really can't. I really can't. And part of that is cultural expectations. When a meeting starts at 8 a.m., I start at 8 a.m. I do, even if you don't show up. I do. Because to me, 8 o'clock is 8 o'clock. But when other people start meetings, and I'm not running that meeting, and it's like 8:15, 8:30, I cannot. I get so irritated. Apparently, that seems to be okay. But feelings, thoughts, and behaviors are culture-bound. Western theories have dominated and continue to do so the ways in which the Filipino experience is analyzed and interpreted. Western theories are taught in local schools, are used in clinical training in psychiatrists, psychologists, and other professions, and are viewed as the model for policy making and program planning. Now, while Western psychology has definitely made important contributions to mental health field in general, an unchallenged assumption is that they depict a true depiction of the Filipino experience. And you know, they don't. This is far from accurate and has inadequate or unfair implications. I highly encourage you to think about Sikuluyang Filipino in the ways in which you do health research and innovation. It is time to bring back the local context. Sikuluyang Filipino is rooted in Filipino thought and experience with a core value, right? With a core value of shared identity or kapwa. It encompasses the entire range of psychological phenomena from awareness to behaviors to motives that are found in other cultures, including the West, but with emphasis on the Filipino orientation. If you read Virgilio Enriquez, he says, there's nothing wrong with Western psychology. There's nothing wrong with it. But why is it prioritized over our own? And that's something to reflect on. And everything I have told you opens us to possibilities for all kinds of mental health research and innovation. Yes, we can take the traditional approach, how many people are depressed, how many people are anxious, blah, blah, blah. It's still important, I think, because we don't have that data. We need that data. We do. But when you think mental health research, it cannot just be that. It cannot just be, because the other stuff is also very interesting. When we expand the definition of mental health, we open ourselves up to exciting avenues for research because we are looking at the psychological dynamics, not only of those people whose behavior we wish to change or influence, but also the behaviors of ourselves. We work on the assumption that research and innovation aim to reduce health inequities. What we seem to ignore is that perhaps our current research and innovation perpetuate inequities because we do not transform the lens through which we conduct research and with which we try to innovate. I love being a psychologist in public health. I hope you join me in expanding our definition of mental health. I hope you join me in helping the new mental health law branch out from a clinical approach to a more ecological approach, where it is truly embracing the tenets of community-based mental health. I hope you join me in conducting research and pushing for innovation where Sikuluyang Filipino is prioritized so that our data is a valid and reliable picture of our Filipino experience. Good afternoon.
Edited.
Thank you, Dr. Del Castillo, and we really enjoyed your very passionate talk. We'll proceed with our open forum. So if you have questions for Dr. Del Castillo, we'll be answering your questions. Okay, sir?
Thank you. I'm sorry I've been approaching the mic for like 3 times already, but anyway, this question is about preferential bias. Would you consider for my study on peer education, wherein local initiatives would assign LGBT orgs to handle HIV related prevention programs as a more of a preferential type of bias? That's one. And then another question is, because HIV problems should supposedly be everyone's problem, I think. But it seems that when I did a study that they've been assigning this to LGBT orgs because they think this is limited to their concern. So that's the first one, if it's preferential bias. And another one is for the crafting of mental health programs, would it be better to actually include more of people who have its, no, not really, of the communities? How do you propose that we include communities in the crafting of the program? That's all.
Yeah, thank you for the question. One, preferential bias is hidden. Like you're not conscious of what you're doing. So from the example you're giving, to me, is not preferential bias because it might be a deliberate action on their part. Now, whether or not that's a good idea or not is a different debate, right? But there is considerable evidence to suggest that we tend to pick people, whatever it is, for a task because we believe that our audience are more likely to identify with that person, and therefore they're more likely to listen to that person, right? So when we're talking about teenage pregnancy among teenage girls, I just don't know how effective it is if an older man does it compared to a younger female facilitator of a roundtable discussion. So I think it's deliberate in that sense because I do think it's effective. Now, having said that, yes, I do wonder, does that perpetuate a kind of image, I don't want to say stereotype, but image about the LGBT community, right? That the LGBT community is just about HIV/AIDS, right? It's a form of microaggression, not preferential bias, right? That a significant number of LGBT research in the Philippines is about HIV/AIDS. It's as if LGBT people have nothing else to do. That says something about our attitudes about LGBT people, right? That's number one. Number two, I'm not easy. How do we involve communities? You ask them to join your programming. And in community-based mental health, we ask people to join from the very beginning until the very end. All right, and that to me, I sat through the working groups and of the mental health law. We did invite people, especially early on, people with mental health problems or orgs, NGOs who supported or spoke on behalf of people with mental health problems. So we did include them in the very beginning, but now there's really only one org who does it. And in community-based mental health, there's the majority of people who should be sitting in those committees are people with mental health problems. Because the only people who are experts in mental health problems are people who have gone through a mental health problem. And that's why you bring them in. Thank you.
Okay. Do you have any other questions for Dr. Del Castillo? Dr. Montoya.
Thank you very much, Dr. Del Castillo, for that very animated talk. Well, just you already know, but community-based psychiatry is being done already in the Philippines, and we've been working closely with the group of Dr. Lourdes Ignacio in this area. But having said that, we had a number of symposia on mental health, and I fully agree with what you're saying, that I think the trend now is really transforming communities, looking at the illness as not just the disease of the individual, but also the disease of the community. I say quote unquote. And I say this because I've heard and seen many stories about families and communities and how they respond to a family member with mental illness. There are quite a few incidents or stories of children being tied, or literally prevented from going out because they were afraid that he will or she will hurt himself or hurt other people. But I think it's more of it's not that. It's really more of you don't want people to take notice that a family member is actually sick, quote unquote. To me, it is a very strong message that when you have someone with a mental health in the family, you have to keep the whole family because there's something wrong with the dynamics. And I'm not saying that they contributed to what happened, but it may be aggravating. So it may not be the best way of rehabilitating such a person. So, but we're developing the modules for community-based psychiatry, teaching, and this is a group of doctor national care workers, midwives, nurses to be trained on psychiatry, because psychiatrists are a dying breed in the Philippines. I know for a fact that there are very few psychiatrists in the Philippines, maybe not in the US, but in the Philippines, they're really a very, very weak. And psychologists also are few. So we need to have people know how to respond, to confront, and to take care of patients, at least initially at the primary care level, and maybe have some specialty work done later. But I think the researchers will really focus on this particular field. That is my thinking. I don't know what your comments are, or maybe other research areas that have to be pursued. Thank you.
Right, I agree. Just to quickly comment, I echo your points. In community-based mental health, the problem is not the patient. The problem is the community. So, when we see people outside, disheveled and dirty, talking to themselves, and we believe them to be psychotic, the problem is us. We didn't do enough. We don't have housing. We didn't connect that person to resources so that he or she can be well. The problem is the community and not the patient. So I definitely echo your sentiments on that. And I think and the beauty about Psicologiang Filipino is that it helps us to integrate and prioritize our understanding of mental health here in the Philippines. So now, in the West, when we use a kind of spiritual explanation, especially for psychotic disorders, right, that's not a good thing. That's scary. But in Psicologiang Filipino, Enrique says, let's entertain it. Let's bring it to the table. That's a possible explanation for why this person is psychotic. That there is because of punishment, it's because of religious reasons. Let's bring it to the table in addition to the other things. The issue that Enriquez points out is that the West tends to dismiss the spiritual aspect explanation. In Psicologiang Filipino, let's bring it in. Let's discuss it. It's probably not the correct explanation for the disorder, but the point is we don't dismiss it. Because dismissing that explanation dismisses the family, and then you lose opportunity for wellness.
One more? Yes?
Yes.
I'm Dr. Lonza Contreras. I'd like to thank you for a very active and very informative sharing today. In light of what you shared with us on mental health, I could see that it was the topic that you were sharing about was more on the extreme end when there are certain really manifested clinical abnormalities. But I belong to the academe, and one of the things that we are concerned about is that we hear about several of students slashing their wrists, thinking about suicide, and we have had several students who have committed suicide or have attempted to commit suicide. And I completely agree with you that it is a community-based mental health. And this is one of the reasons why we have in our college a program which we call New Beginnings, which is a faculty staff mentoring program. So that we can be able to reach out to the students, not really, because basically we are not that equipped and we feel rather helpless when we encounter these situations with students. But the best that we can do is just provide an environment where they can be able to talk, relax maybe, and just and allow them to ask questions. If we do not know the answer, we just need to say we do not know the answer. But we will talk about it. Thank you.
Thank you. That's an excellent point. And that's why I invite you to think of to define mental health broadly and not just depression or anxiety. Because you're absolutely right. All of that. Stress is a mental health thing. The majority of people, that's why the beauty of community-based mental health means that you, as teachers, as professionals, as whoever, can do mental health-related interventions without me as the expert. I don't mean to toot my own horn, but I am expensive. Seeing me for an hour will cost you a lot. And you know what I do the entire time? Yeah, I hear what you're saying. I get paid a lot just to do that. But the majority of mental health issues don't require me. They don't. The majority of mental health issues don't require a psychologist or a psychiatrist or any other mental health professional. That's why when I was invited to the Philippine Science High School recently to give a talk on how to help the teachers, I was excited because teachers can do a lot of supportive listening and simple supportive statements. You look sad. See, a simple supportive statement that a lot of people can do, and if a lot of people in our community do that, then you promote and protect mental wellness so that only a minuscule number of people then will need to pay and see me. Okay? So the majority, including everybody here, can definitely do mental health related work. Thank you.
Okay. Do you have any more questions? No more? Okay. We'd like to thank Dr. Dan Castillo for his talk. And I'd like to inform you, I'm happy to tell you that we're on time. Okay. So we're down to our last parts of our forum for today. And I'm actually tasked to give a synthesis of our three very remarkable talks for today. And these topics are really very timely. And the real problems were presented by our presenters.
Next one.
These are real problems of the community and our country today. So Dr. Salvania talked about the HIV epidemic in the Philippines. And Dr. Eugenio already talked about the teenage pregnancy and sexual health. And of course, our last speaker, Dr. Del Castillo, talked about mental health, helping us understand what mental health is and mental wellness is. And all of them presented challenges to us, to be part of the move, to talk about these topics, learn more about these topics. So for Dr. Silvano's talk, I learned a lot about HIV being a genetically diverse disease. And the Philippines is a red area, okay? And that's truly alarming because we have the highest prevalence of HIV, fastest growing prevalence in the Asia Pacific. So although we have seen a lot of patients improve on treatment, you mentioned about treatment failure, and that's about 10% of treatment failures. And this is very important because we have to really, we as health researchers have to work on this and to decrease resistance of HIV. And as part of the stakeholders, we also have to increase the awareness for HIV. And for Dr. Eugenio's talk regarding teenage pregnancy, we already know that there's increase in the teenage pregnancy among poor communities, and for those who gets married earlier, or those who have cohabitation early on. So in these areas of, in parts of her research, maybe we have a lot of different views regarding this topic, regarding reproductive health. But Dr. Montoya told us about our main concern. It's still the health of our teenage moms, our teenage parents, and their children. And we want to decrease the mortality and morbidity of these patients. So we really have a big work to do in terms of intervention in pregnancy, in teenage pregnancy, considering our social-cultural uniqueness. And regarding mental health, I really learned a lot about this topic. And we want to really go for transformative change, as Dr. Del Castillo said. So we want to be partners in developing the community-based health programs. And in our own little ways, I think we can help out in maybe extending an ear to listen to our students, no, to our co-workers. So I think in our own little way, we can help promote mental health wellness. Is that right? Okay? So I think mental health, what really captured my understanding is that what I got from this is that mental health is thinking, feeling, and behaving. It's not an illness, so we have to expand our understanding about mental health, and we have to deal with it day by day or every day of our lives. So we should all be partners in this endeavor. Okay? So the challenges are really there, no? So all these topics, we have more research to do, no? For us as health researchers, we have more things to learn, and we have more things to do. So I hope that we will all be partners in creating change, no? In our community, in our health system. Okay? So with that, we'd like to go to the last part of our program, which is the awarding of the certificates for our speakers. We'd like to call Dr. Montoya to accompany me award the certificates. So we would like to present the certificate of appreciation to Dr. Limpa Ohenia in the citation reads for her invaluable contribution as speaker in the session From Research to Public Health Programs, Forum on Sexual Reproductive Health, HIV, Teenage Pregnancy and Mental Health during the 12th PHILIPPINE conference given this 8th day of August 2018 at Cap John Hay Trade and Cultural Center, Baguio City. Signed by Maria Geraldine Casipit, Chair of the Cordillera Regional Health Research Development Consortium, and Dr. Jaime Montoya, the Lead Coordinator of PNHRS. I would like to call on also Dr. Ronald T. Del Castillo for his invaluable contribution as speaker in the session From Research to Public Health Programs, Forum on Sexual Reproductive Health, HIV, Teenage Pregnancy, and Mental Health during the 12th PNHRS Week conference given this 8th day of August 2018 at Cap John Hay Trade and Cultural Center, Baguio City. Signed, Maria Geraldine Casipit, Chair of the CRH-RTC, and Dr. Jaime Montoya, Lead Coordinator of PNHRS.
And also the PNHRS would like to present the certificate of appreciation to Dr. Marie Elaine Velasquez for her invaluable contribution as moderator in our session From Research to Public Health Programs during the 12th PHILIPPINE Week Conference, Research Innovation for Equity in Health, this 8th day of August 2018 at Cap John Hay Trade Cultural Center, Baguio City, run by Dr. Maria Geraldine Casipit and Dr. Jaime Montoya.
So before we end, we would like to take this opportunity to inform everyone that PCHRD is currently working on the preparation of the mental health research agenda for 2018 to 2022. It is to be noted that there is an increasing prevalence of mental health and psychosocial disorders in the country, but there is meager data and knowledge base on this topic. Mental health is one of the priorities identified in the National Unified Health Research Agenda for 2017 to 2022, and it will be a new research program for PCHRD. The Mental Health Research Agenda will guide PCHRD and other stakeholders on the priority research topics, as well as in the evaluation and funding of research projects, especially on mental health science and technology. PCHRD partnered with the World Association of Psychosocial Rehabilitation Philippines in preparing the Mental Health Research Agenda. This will involve regional consultations among stakeholders. We hope that you would support us in this endeavor towards bringing mental health from the periphery to the center of health research and healthcare. Thank you very much. We would like to close this session, so we'd like to see you in the fellowship night